It's great to connect with everyone today. Thank you for the opportunity to speak to some of the work that we've been doing. So the Frontenac Lennox Addington OHT is made up of over 80 partners. So this includes community agencies, municipalities, a very engaged community council, 160 family doctors, and 3 hospitals. We serve a population of approximately 210,000 people. This area is very diverse. It's composed of vibrant urban cities, picturesque villages along Lake Ontario, Tyendinaga Mohawk territory, and many rural and remote areas. So the FLA OHT received funding to begin the work on ICPs for heart failure and COPD in October of 2023. Similar to the other groups, we had early co-design engagements with our primary care network, community council, and Indigenous Health Council. Which contributed to the development of the ICPs. Assessment before implementation revealed some key opportunities for change. So for heart failure, one opportunity in our region was that the care for heart failure was described as siloed care. No formal relationship or coordination really existed between the spokes, hubs, and the nodes. And this contributed to long wait times at the Kingston Health Sciences Heart Function Clinic. That is our largest regional hospital, and ultimately that leads to delays in care for people. Dissolving these silos would improve wait times and access to care. Additionally, the care provided by each level was another area for improvement. So spoke level care was seen as suboptimal in the primary care diagnosis and management, was not well organized with clear evidence-based pathways easily accessible to them. So this is an opportunity for education and implementation of those standard care pathways. Finally, community paramedics have the ability to respond to heart failure referrals, but this was not coordinated at the hubs or nodes in our region. And that limits the long-term effectiveness of their interventions. Importantly, each of the OHT partners has shown a deep level of initiative and willingness to collaborate and deliver best care to our population. For COPD, other opportunities were revealed. So the FLA OHT has a higher proportion of older people than average in Ontario and a significant rurality index. So what does that mean? Travel and costs can make it very difficult for people to access spirometry, for example, for COPD diagnosis. There's a real opportunity for the ICP to bring that closer to home for people. And care received by people with COPD was very heterogeneous, so very similar to heart failure. An opportunity to standardize that care pathway for primary care was seen as a chance for us as well. And lastly, neither of the 2 pulmonary rehab programs in our region provided virtual access to care. So in knowing our region, virtual pulmonary rehab has enormous practical advantages, considering we're a rural area and there was limited access to in-person rehab at the time of implementation. In addition, about 20% of our population does not have a primary care physician before our implementation year. So this posed a major gap in care and obstacle to implementation for the ICPs. The mission of the FLA OHT is to have every single person attached to a people-centered health home, which will have the largest impact on people's health and wellness, including those living with chronic disease. So in generating a deep understanding of the current state of care for these 2 chronic diseases and being driven by our guiding principles, we began the work of implementing ICPs this year. So our team began identifying key initiatives that would expand capacity, create more efficient care transitions, and provide better access to services. So whether it be something like the pulmonary rehabilitation that I was just talking about, or access to a family doctor. So all of the initiatives were really aimed to address those opportunities for change that we identified. And I won't go into them in super detail. Hopefully we'll be able to share those slides after the session. I would like to share just some of the results of these initiatives, something that we're really proud of, and some really incredible outcomes so far. So our team actually trained 86 personnel across the region, including 65 primary care providers. So there was a pathway document, that care management pathway. That pathway document, we educated those primary care providers on. We collaborated with them to create a shared understanding of the pathways. We trained 6 Ontario Health at Home nurses, 12 community paramedics, and 3 care transition nurses at Kingston Health Sciences. We hired 7 personnel, including a heart failure nurse practitioner, a heart failure physician assistant, a project assistant, a COPD nurse navigator, an ICP project manager, and 2 best care, they're called certified integrated disease clinicians, but we'll call them educators just to keep it easy. And then we also developed several new protocols. For example, the engagements with community paramedics. They have a home visit program, and we've established a new protocol with them to administer home IV Lasix. In addition, we created escalation and de-escalation protocols with Ontario Health at Home for heart failure. So a lot of this was creating efficiencies between different care providers and moving within their full scope of practice. Our team also reviewed emergency room data and connected people with the care that they needed, including connecting 50 people to a primary care provider in the region to receive care that they needed. The Heart Function Clinic at Kingston Health Sciences is our heart failure node, and it increased its capacity by 50% this year, decreased wait times by a median from 92 days down to 43 days. This clinic has also seen optimized specialist access as well. So based on our local available data, the number of anticipated new patients being seen within the Heart Function Clinic is actually going to be similar last year to this year. But what has changed is the category of patients. So the Heart Function Clinic is now seeing more urgent people through active diversion to the general cardiology group. So they're seeing more appropriate patients within that node, and that's resulting in better care. And to speak a little bit to the best care pilot, so we did embed 2 educators across 7 FITs in our region. So that included actually 10 sites. And our best care pilot resulted in 250 visits for people with COPD. More to come on heart failure. We just implemented last quarter, so we're waiting on that first set of data from them. But through best care, we learned that actually more about the people in our region, like their number of PAC years. So for our region, Best Care is actually seeing that we have a higher number of PAC years compared to the other folks that they're seeing across the province. Our goal classification is slightly different than the people that they're seeing outside the rest of the province. And importantly, Best Care worked to really shift the number of people on triple therapy and reduced the number of people on no daily controller therapy for COPD. So that could have a huge impact as well. So we're still in the process of gathering all of the data from the various initiatives, definitely more to come. So we just wanted to share a little bit about how the implementation went throughout the year to provide, we were talking about building blocks to success. So over time, Q1 required a significant amount of ramp up. And I started with the team in May. Over the summer, we did implement several key initiatives. And after Q2, we actually started to see some changes. So the ICP implementation OHTs, they actually have a dashboard through Ontario Health, and that dashboard is available for us to check quarterly values against other OHTs, against the province. So within that dashboard, we actually started to see shifts in the admission rates and ED visits here. These values represent a % decrease up to Q2 as compared to our baseline year. In the fall, we ramped up and continued to build on our momentum with ongoing training initiatives. Rapid access clinics were launched. An important shift in our region was happening at this time. So the transition to Lumio, which is our new health information system for the entire Southeast region, that included all 3 of our hospitals. So that happened in December. This shift did result in changes to how we track, report, access data. It was felt from both the hospital and the community partner settings. And so it was really important to understand that impact as we did our implementation. Despite this, again, our ICP dashboard metrics continue to improve into Q3. We are waiting on Q4 data, so we'll see the full picture soon. And just for other ICP teams, if you are looking to do this type of analysis, like against your initiatives versus the dashboard, when OH updates the dashboard, you will lose the previous quarter's data. So I was actually saving the raw values in a separate Excel. So I just recommend if there are other teams that kind of want to do this sort of mapping to do that if you can. So here you can see our year-over-year trends for the region. Again, this is from the dashboard. Each of these metrics are trending downward. It's great to see. Again, more to come once Q4 is released. And just note that these results are occurring even while prevalence of both diseases is going up in our region. Outcomes relating to the Best Care pilot, they found that 38% of people that they saw had exacerbated the year prior to being seen. But only two people have presented to the ED since they've been seen by Best Care, and 0 have been hospitalized. So some really encouraging results out of the pilot as well. So we mapped at the beginning, so now it's time to map since implementation. It's an iterative process, as the other groups have mentioned. Some key enablers for mapping include clearly defined care provider roles, ensuring that we understand the full scope of those roles so that stronger connections can be made between them. So tying this work back to the health home model, the ICPs complement this work by ensuring that those who are unattached are connected to a primary care provider, which requires integration with our PCN or care provider network. We focused on building capacity in primary care for chronic disease identification and management through initiatives like the Best Care pilot and collaboration sessions, or those education opportunities that we had, and working to streamline referrals and strengthen partnerships. We also enhanced resource navigation, similar to the other groups. They mentioned, resource mapping. We also did this. We created the map of our region, and it's available on the OHT website as well for the public. But we used it also in the work in designing the pathway. Enablers have been to recruit really highly engaged, respected, wonderful leaders as pathway leads. We are so fortunate to have Dr. Miflay and Dr. Fitzpatrick as our pathway leads. They have been such advocates for the work, and it really builds relationships when you have those people in those roles. Creating opportunities for connection and collaboration across the different providers. So doing those education sessions really turned into something really powerful. It built relationships across the providers in the region. And the pathway documents and maps allow for a shared understanding of the pathway and what it means for each of the care providers. Lessons learned: map your pathway early, identify silos and also overlaps. There may be some that are doing similar things. You should identify those early if you can. Tracks as many local metrics as possible. Highly recommend that. Understand each organization's priorities to estimate the impacts of implementation, especially partners tackling an internal transition like Lumio in our case, and establish MOUs and agreements early in implementation to avoid any delays. So if you have procurement that you plan to do, if you're hiring folks, those agreements are really key to move that work forward quickly.